Okay, so round two, everyone. Welcome to the scooter-related injury webinar this morning. And thanks for your patience while we sort out those technical difficulties as well. So before I get started, I'd just like to acknowledge the traditional owners of the land in which I deliver this webinar from this morning, the Whadjuk Noongar peoples. And I'd also like to extend our acknowledgement to the traditional owners of the lands in which people are dialing in from today, and pay our respects to the elders past, present and emerging. So just for anyone that might not be familiar with Zoom this morning, I just wanted to remind everyone to please double check that their microphones are muted. This will just allow us to make sure that we're hearing our presenters nice and clearly this morning. We'd also love to hear your questions, so I do strongly encourage you to please send them through in our chat tab, and we'll go through these at the end of the presentation. If you've got more than one person in the room with you listening in today, could you please just send us a quick private message via the chat tab as well, and just let us know how many people are listening to the webinar with you. And if you do also face any technical difficulties during the presentations today, please send us a message in the chat box and we'll do our best to help you out with this. So today's webinar is brought to you in partnership with Injury Matters and the Australasian Injury Prevention Network. So established in 1996, the Australasian Injury Prevention Network, or the AIPN, is a member-based organisation that reflects individuals and organisations across the state and local government, industry, not-for-profit organisations and academic institutions. The multi-sectoral and multidisciplinary membership of the AIPN enables the AIPN to draw from nationally and internationally recognised expertise across a diversity of injury prevention areas. So the AIPN engages with its members through monthly newsletters, webinars, the AIPN website, and through the biennial Australasian Injury Prevention and Safety Promotion Conference. And just a quick overview of Injury Matters for those of you that might not be familiar with us. So we're for safer people and places. We're a not-for-profit organisation and we aim to prevent and reduce the impact of injury within the WA community. And we do this through advocating and providing education for injury prevention, as well as providing support for those that are impacted by injury. So today's webinar is delivered through our No Injury program with the support of the WA Department of Health. And the No Injury program is a statewide program and it aims to enhance the capacity of injury prevention and safety promotion practitioners such as yourselves to deliver quality injury prevention activities. And through the No Injury program, we provide training, events, resources and networking opportunities to support injury prevention throughout the sector. Given the diversity of injury in WA, the program involves a large variety of injury topics, which includes transport, which is the focus of today's training. So just to set the scene a little bit for this morning, in 2020, there were 155 fatalities on WA roads. In addition to these fatalities, over 1,500 people are seriously injured every year on WA roads. Due to motor vehicles, bicycles and pedestrians being involved in the majority of transport incidents in WA, they generally are the focus of transport-related injury prevention initiatives. However, given the variety in our transport routes, our demographics, access to vehicles and a preference for physical activity, Western Australians use a variety of transport devices to get from point A to point B, and therefore injuries can result from a variety of different transportation types. So today our focus will be on some high-risk transportation devices by exploring the incidence of injury due to e-scooter and mobility scooter use. So electronic scooter shared services, also known as e-scooters, have rapidly expanded across the world as a convenient option for short trips and as a novelty recreation or tourism activity. In WA, shared services have not gained as much traction as the eastern states. However, purchasing of e-scooters for private use is becoming a common purchase. In other states, as the popularity of e-scooter use has grown, the incidence of injuries has increased to both users and pedestrians. These injuries can result from the transportation use of the scooter or environmental hazards that scooters can pose in public places as well. So these risks reinforce the need for additional safety legislation and initiatives in WA to support the safe use of e-scooters. So if we have a look at mobility scooters, quite similar to e-scooters, it is anticipated that the use of mobility scooters as an individual's primary method of transportation is expected to increase quite significantly in the future due to our ageing population in WA. Mobility scooters do bring independence and movement to many people who would otherwise have difficulty getting around their community, and therefore recognised as a key tool to enable people to remain independent for as long as possible. Despite their accessibility benefits, if the driver carries poor vision, strength, coordination or balance, mobility scooters can unfortunately pose significant risk of injury, especially in relation to falls and collisions with pedestrians or other vehicles. So in order to work towards our current road safety goal of a 50 to 70% reduction in the numbers of people killed or seriously injured on WA roads by 2030, it's vital that we evolve our prevention efforts alongside the transportation devices that Western Australians are using. So to continue this discussion regarding scooter-related injuries, I'd now like to introduce you to Professor Kirsten Vallmuur from the Queensland University of Technology. So Professor Kirsten Vallmuur is the Chair of Trauma Surveillance and Data Analytics, which is a joint position between the Queensland University of Technology and the Jamieson Trauma Institute that is funded by the Motor Accident Insurance Commission. In this role, Kirsten leads the Jamieson Trauma Institute's Trauma Data Quality and Analytics theme. Her team is currently undertaking research projects drawing on linked trauma data available through existing data systems in Queensland. The work of the unit is focused on scoping the breadth and depth of data collected on trauma across the continuum of care, developing best practice methods and tools fusing linked trauma data, and analysing these data sources to better understand the causes, trends, patterns, burden and cost of trauma in Queensland. So I'd now like to introduce Kirsten. And I'll just get you to share your slide now, Kirsten.
I'll just need you to unshare, Jo, because I can't share while you're sharing, sorry. Okay. Everyone can see that, I'm sure. Can you give me a thumbs up, Jo, if that's showing okay? Okay, I'm presuming it's okay. I'm not getting any chat to say otherwise. Let's have a look. Okay, thanks everybody. Never quite sure with these things. Okay, so today I'll be presenting the work that we've been doing in Queensland on EPMD related injuries, which largely refers to e-scooters. They're our predominant EPMDs. But just so that people know what I'm talking about when I talk about EPMDs, EPMDs include a range of different powered mobility vehicles. They range from cycling, scooters, self-balancing boards, skates, one wheels, etc. The predominant type in the data that I'm talking about today, though, will be e-scooters. So just to give a bit of international context, Jo painted a bit of the picture before when she was talking about this, but shareable e-scooters trials have been occurring around the world since September 2017, and they started in California with the Bird e-scooters. There's been a significant increase in the sales of personal mobility devices internationally, and shared e-scooters are estimated to top 4.6 million by 2024. There's been an estimated 55 deaths worldwide as of April 2021, And studies by the CDC in Austin estimated 20 injuries per 100,000 trips of e-scooters. Our Brisbane data suggests that this is more around 28 injuries per 100,000 trips, but as you'll see through the talk today, estimates are quite difficult to come about for these. And there's international collaborative effort to define micromobility and provide frameworks for safety, and also to introduce product standards around these, but this is all work in progress currently. So just to give you the Australian context, there's different rules and regulations across each state and territory around personal mobility devices, speed restrictions, whether there's share schemes or not operating in those states. Most of the states allow EPMDs in public, other than South Australia and New South Wales. Many of the states have a limit of around 10 to 15 kilometres per hour, other than Queensland, where we allow them to get up to 25 kilometres per hour. And in terms of shared schemes, the three that have current active shared schemes that we're aware of are Queensland, ACT and Northern Territory. A couple of the other states have had trials or are expecting possible trials this year. So Brisbane was the first Australian city to trial shareable e-scooters, and this was mid-November 2018, and there was a temporary exemption from the Queensland road rules. So Queensland road rules were changed actually within 1 month to accommodate EPMDs around this time. So essentially in Brisbane, you must ride on a footpath, and this includes separated paths where you must ride on the bicycle side of the path, or in local streets that are 50 k's or less where there's no dividing lane. So essentially this is not any of the CBD streets that you can see in this photo here, or main roads, or on-road bicycle lanes, or pedestrian-only lanes. So it's quite a complex web where you can and can't ride. And in terms of having a continuous commute, you could see the challenges with that in an area that changes quite rapidly. There must be at least 16 years of age or 12 with adult supervision, wear an approved bicycle helmet, and in Queensland there must be lights displayed front and back of the scooter. They must not travel over a maximum speed of 25 k's, but there's many on the market that travel way faster than that, and there's incidents in Queensland of scooter riders being clocked at way over 60 kilometres an hour. Mustn't carry passengers or use a mobile device while riding them, or drink and ride. So in terms of some of the injury prevention challenges that these represent, defining the problem is a real issue with these cases. The rapid implementation, especially of trials and of the expanding range of products available, limits the opportunities to implement prospective surveillance. So we often rely on retrospective injury data. Many of these incidents are out of the scope of road crash data unless they're actually occurring on the road and in collision with the vehicle. There's challenges when we talk about injury data in terms of quantifying these, because there's limitations in the coding systems that have been set up to capture case products that we know about, and they don't particularly capture those well, to be honest. Therefore, we often have to rely on text fields from injury data to be able to identify whatever cases we can find. And within that, there's a lack of standardisation of descriptions of EPMDs and injury text. So we have a challenge of being specific versus sensitive in our case capture methods. There's also very unwieldy ethics and governance processes for accessing timely injury data, as anyone would know in this space. In terms of identifying risk and protective factors, when we are using injury data, there can sometimes be a lack of completeness of capture of certain factors. While things like helmets can be recorded because they impact on clinical care, some of the other factors around things like alcohol, speed, faults with the product, pedestrian collisions, etc., can be quite difficult to identify. And we have the challenge of how do we interpret null values? Does it mean it didn't happen, or does it mean it wasn't reported? There's also a reluctance to release injury and or exposure data by companies. And then in terms of developing and implementing prevention strategies, there's conflict between innovative mobility enthusiasts and other road use advocacy groups such as pedestrian councils, cycling councils and so on. And that's an ongoing discussion. There's also challenges in terms of regulation, enforcement and response, because this is the domain of multiple agencies. And I've just got a pictorial to demonstrate this. So in terms of things like the scooters themselves, share scheme permits are often the responsibility of local councils. When we talk about the roads and the legislation and the infrastructure, local and state and national transport departments set those laws in place. Compliance with the laws, the police are responsible for overseeing things like helmet use, alcohol, speeding, etc. If the person was commuting to work at the time and had an incident, workplace health and safety come into play. When we talk about other community groups, community safety issues, pedestrian safety, bicycle advocacy, ageing and disability groups have a stake in this area. We might also be talking about the product itself and product fault, particularly when we're talking about private mobility scooters. So this is where state and national product safety regulators come into play. If someone's injured in the incident, where there's a range of different people get involved, from ambulance, emergencies, hospital, maybe compensation providers and health insurers. When we talk about the sale of the products, we have retailers providing information about their use. The products themselves, we have manufacturers involved in vehicle design and standards compliance. And then we get into things like education and messaging, where council, state governments and media all have a role to play. So you can see the range of different people involved in these products. And quite commonly in many injury areas, we see this same kind of complex web of regulators and stakeholders involved. So how do we approach the issue in Queensland? So what I plan on doing is kind of walking you through from the moment that e-scooters hit the shores in Queensland, in Brisbane, through to just this week when the latest strategy was released, just to show you how we've engaged with the different stakeholders and tried to use as much of the evidence as we can gather to influence positive change throughout that time. So these came into play mid-November 2018. And at that time, the College of Surgeons straight away identified some of the challenges and issues that they saw with these devices. We've got quite an active Queensland Trauma Committee, which engages really closely with the National Trauma Committee, and at both a state and a national level, there was a lot of discussion about EPMDs and what our response would be as an injury prevention community. So at that time, knowing that there would be difficulties in obtaining data about these kinds of devices and the challenges with that, we reached out really quickly through our network of emergency departments, ambulance and our contacts in workers' compensation to ask them to start flagging these kinds of cases prospectively as they came into the system. We put flyers around the main EDs where people would be turning up if they'd had an injury, and described for the ED staff the kinds of things we'd need them to document so that we knew we'd be able to go back and capture as many cases as we could to understand the numbers of cases that we were seeing, because we knew it'd be important to make sure that we captured some information about what was happening in terms of injuries once these devices hit the street. What we did with that, because the request came from the College of Surgeons and there's good relationships between College of Surgeons and data providers at those areas, they could provide us de-identified aggregate type figures so that we could compile some numbers and understand what the patterns were over that time. So early in January, we reached back out to those groups and asked them to compile the data and send that through. And at Jamison Trauma Institute, we put those figures together and started being able to have some numbers that we could provide to the stakeholders to let them know what kinds of things were going on and what patterns we were seeing. So at that time, there was around 134 patients that had presented over that 2-month odd period over the Christmas time. And the 20 to 34-year-olds were the main age group that we saw the issues occurring, with about 11% of cases admitted to hospital at that time. So what we did with that data was put together a brief summary report, which we sent out to Transport and Main Road stakeholders and Brisbane City Council. We also, at the time, there was a National Transport Commission inquiry into this. So with this area, there's both state and national bodies of work that have been going on. So we've been trying to make sure that we target both of those, because both have an influence in terms of how this will roll out in the future. So on both levels, we tried to compile information for our local parties and also information for our national parties. This then obviously was quite of interest to the media, so there was a little bit of uptake in the media and got some conversation going in the community. Then over the following period, we're talking around the 2019 period, colleagues of ours put together some of that data from the Royal Brisbane Hospital and put out a paper in that area for the 8-week period. And there was also an editorial that Ruth Barker rate, and we did a presentation at the AIPN injury conference, and we also went through the, if you can read that there, unwieldy process of research ethics and governance, because we also knew all the broad data is useful, and that kind of aggregate de-identified fairly broad data that we could obtain through those networks of clinical networks. We knew that we needed to get further information about what was going on and do some chart audits and really get down to some more detailed information about how the injuries occurred. So we went through that process, and that was quite a lengthy process to get all the approvals we needed for different hospitals. From that, the work through 2019, we were still waiting on our data and our research sign-offs. However, we used what we could obtain over that time through those other broad data requests to put together another response to the National Trauma Commission, the National Transport Commission, sorry, that had a further regulatory impact statement. So we sent that through to that group as well. By this time, we're talking towards September 2019. By this stage, we're up to around 447 cases over that period, and similar patterns to what we'd seen in that early 8-week block, similar age groups, similar proportions admitted to hospital, and similar days of the week of concern. So 2020, we got all of our rubber stamps for our research data to progress. We've started through 2020 doing all of the chart reviews, setting up the processes in place for the hospitals and getting people collecting data out of the charts for those cases. And our data collection is actually going up till the end of 2020. So we're still actually in the process of doing a lot of that data collection, but we've been trying to compile and put together charts and figures as we move through that so that we can have data available and on hand. So this is still work in progress that I'll be talking about today. So we've used what we had already obtained and put together to then respond to the Brisbane e-mobility strategy draft that came out at the end of 2020. We submitted some information that we had to that group in early 2020. So I'll talk you through some of those results. So these are the most recent results that we have that we compiled to provide to those stakeholders at that time. So this is showing the pattern over time from November 2018 when the e-scooters came into place. And so this is, just as a reminder too, we've selected all EPMDs, but the largest majority of the cases that come through are e-scooters, and some of the latter slides break that up for you. But essentially when you're looking at these, you can comfortably say that most of the patterns are due to the e-scooters. So you can see that early flurry of activity and higher injuries in that early on in that piece that kind of tapered off for a while. And some of those latter in April, May 2020, we saw some impact of COVID, obviously of people not moving around. But they're saying now that with e-scooters, we're back to the pre-COVID levels of use of e-scooters. We're not seeing that with our public transport in Queensland. They're saying it's still around 70%. So it's really returned to usual levels of use. Our colleagues at Brisbane City Council, when we provided these figures, were interested to see how this overlaid with, if they overlaid the share scheme e-scooter trips over this. And it was quite interesting to see that there was quite a common trend, both in the numbers, how the pattern flowed for the numbers of injuries and how the pattern flowed for the number of e-scooter trips. You can see that that line marries up quite nicely across there. So of these, as I said, 734, 92% of the cases that we've compiled were e-scooters. We're now up to 801 confirmed EPMD related presentations, and that was up until May 2020. There is a bit of work that they're still doing around reviewing charts and compiling the data to be as accurate as possible. So some of these numbers will change as we compile extra figures. Males, like with most injuries, are 60-odd% of the cases. We see our largest age group being the 25 to 35-year-olds. Ambulance arrivals are around 34% of the cases. And our admitted to hospital rate for electric scooters, and I'll just talk more about the electric scooters on this particular table here, we were up to now 17% or so admitted to hospital. As you saw earlier in the piece, it was around the 11% mark. So we'll be looking at what happened with that when we get that full chart review going on to see if there's potentially increasing severity or what's happened to make that number grow over that time. So in terms of follow-up after ED, at the time when we put this data together, we only had one hospital that had really started digging down into the chart audit that we could compile information about that follow-up treatment. We'll have this for the full cohort once we finish that data review. But even just with those particular cases, that 116 from that hospital, 73% required follow-up treatment, 33% at GP clinics, and 41% were attending different types of clinics such as fracture, orthopaedic, etc. In terms of the nature of injury, the predominant nature of injuries is fractures. We see some superficial contusions and so on coming into the ED, but we also see things at the other end of the extreme, quite serious injuries with head or spinal injuries. When we look at the days of the week, the most common days of the week where we have presentations to the ED are on Sundays and Mondays. Mondays, most likely the hangover effect after a weekend where people wake up and decide that there's an injury that needs to be seen, rather than particularly Mondays when the injuries are occurring on. There is some substance of that on Mondays, but we are seeing some delays in presentation with people presenting. And then when we look at the times and the days of the week, the predominant times are the 12 to 6 p.m. Saturday and 12 to midnight on Sunday are our common times of presentations to ED. So the recommendations that we gave to Brisbane City Council around the e-mobility strategy and making use of our data to be able to provide some influence as to what we think needed to be in there around the safety aspect of the strategy was firstly that there needed to be further development of safety strategies with incorporating people from multiple different agencies. Those who had a role in enforcing, monitoring and responding needed to come together to be able to identify what we were seeing through our own, from our own domains and how we could work together to address those significant issues. The initial recommendations were around introducing a mandatory requirement for regular provision of injury and safety incident data to stakeholders, so a regular provision by the share scheme operators, because currently that data sits with them and they're not required to release it. To restrict the hours of operation to avoid those high-risk evening periods. To require a portion of revenue to feed back into the injury surveillance system development, and also to feed back into the increased enforcement costs, because these are having a significant impact on policing, particularly in those times where they're already under demand late at night and in certain high pedestrian areas. Also, to incentivise technological developments with the PMD manufacturers and providers, things that may limit drunk riding or improve helmet compliance or limit dual rider use, things which might provide crash detection and reporting, and also detect product failure to prevent further use. So the initial draft of the safety recommendations for the e-mobility strategy there was three main suggestions that came out in the first consultation draft. And you can read those there around statewide safety programs, advocating with Queensland government to enforce helmet usage, etc. So we worked with them. We had a series of meetings and provided a massive amount of data to them that we could provide from the work that we'd done. And only just this week, the new strategy came out, and I think this strategy document will be of interest to other jurisdictions that are looking to see how Brisbane's operating in this space. What we were particularly excited about was to see how well engaged City Council were with the recommendations that we'd provided and how open they were to introducing those into the final document. We can see that there was 5 extra recommendations that came in that really made it quite a lot more specific about where the safety issues were. So things such as limiting speeds in high pedestrian areas, which is a significant concern, particularly for pedestrian advocacy groups, disability and aged care advocacy groups. Considering restricting operations for share scheme to reduce injury rates, so around those late night and in high pedestrian precincts. Having a collaborative approach with Queensland Police, medical research institutes and Transport and Main Roads to further map out that rider behaviour and compliance, and to identify opportunities for programs to reduce injury risk. Also to require share scheme operators to carry third-party insurance as part of their operating agreement, which is really, really important for people who are injured to have some way of obtaining access to funds for compensation if they have an injury while using these devices, or for people who are injured by these devices if someone's riding them. And also to require share scheme operators to routinely share their injury and crash data as part of their operating agreements. Media, again, we're quite interested in this, and we got a bit of media coverage this week with the local paper. So we're doing ongoing EPMD research. I won't go into this too much in the interest of time. However, the chart reviews that we're doing will continue that data through to the end of 2020, possibly beyond as well, and really delve into more detail that we can gather around the circumstances, the locations, what are the kinds of injury diagnoses and comorbidities, and treatment information, so we can really put a good picture around what the health system effects are of the injuries obtained from these devices. There's many more devices to come, so this will be an ongoing challenge where we need to have responsive surveillance systems to be able to identify and capture this information and have quick ways of communicating that. So key take-home messages that I have today: the data are critical. Even the basic data that we had opened doors and opened ears. We didn't need a massive comprehensive list of data to be able to get the conversations going. More important though is the trust between the stakeholders and transparency in that communication. So having that back and forth flow of information between the groups so that we were on the same page was really important. The conversations need to start early, ideally pre-implementation, to enable proactive engagement and ways to set up prospective monitoring. We weren't in that position, but we quickly, within a month, had put in a system to be able to identify cases as they came in the door to the best of our ability. The interagency partnerships are needed to understand the issues from different perspectives and to share data and identify what those priorities and opportunities are. And we've really, in the last few months, have really started to kick that into gear now. The rapid surveillance also requires existing trustful relationships between authorised data requesters and data providers. We wouldn't have been able to access even that aggregate data from those groups without existing relationships that have been established through our networks. And the richer data is only possible through in-depth chart reviews and linkages. So starting research project requests early, knowing that they take an exorbitant amount of time to get through the system to be able to establish. So this wouldn't happen without a massive team of really dedicated people, and I really want to thank my team. I've listed the names here, but particularly Tori, Brett, Jess and Tanya within the JTI team have really been serious advocates and pushing this through and enabling very quick data delivery as we need it. Also, our contacts at the hospitals that we have been instrumental in getting access to that data and keeping the system flowing. So I will close there and I'll stop sharing my screen, and hopefully I was close to time.
Thank you, Kirsten, for such a comprehensive presentation, and well done on the release of the e-mobility strategy. We can certainly share that around with everyone. So just shifting our focus to mobility scooters for the second half of this webinar, I'd now like to introduce Professor Joan Ozanne-Smith. So Professor Joan heads the Injury Prevention Research Unit at the Monash University Department of Forensic Medicine. She has qualifications in medicine, public health and sociology. Her injury prevention research is multidisciplinary and it interfaces the methods of epidemiology and public health with those other disciplines and includes injury prevention in low and middle income countries, as well as drowning prevention, product safety and injury data systems. Joan's research team first identified motorised mobility scooter-related injuries as an emerging problem in 2006. Since then, she's had an ongoing research interest in retaining the mobility of older persons while reducing risk associated with motorised mobility scooters. So I'll now welcome you, Joan, and please share your screen.
Thank you.
So thank you for the invitation to speak today. An overview of what I'll be speaking about. I'll be talking about the incidence and severity of injuries from motorised mobility scooters, key risk factors, and initiatives to reduce the incidence of these injuries, and importantly, what needs to happen in Australia to prevent future motorised mobility scooter-related injuries. The background to this problem, as Joan mentioned, we first identified deaths and injuries in Australia in 2006. And there's been an apparent steady increase in motorised mobility scooter uptake by users. Few regulations have applied to these motorised mobility scooters. And again, as for the e-scooters, there's responsibility across multiple government jurisdictions, which include the ACCC, the Therapeutic Goods Administration, the State Roads Authorities, and the National Transport Commission. There's been limited uptake of research-based recommendations. And in 2018, there was a Senate inquiry that was reported in September of that year on the need for regulation of motorised mobility scooters, also known as electric wheelchairs. And obviously that definition was confused because motorised mobility scooters and electric wheelchairs are quite different, or they're both referred to together as motorised mobility devices. So the methods for what I'm going to report today are, we looked at fatality data taken from the National Coronial Information System from 2000 to 2018 for closed cases that had been investigated by coroners. And the Victorian Injury Surveillance Unit provided non-fatal hospital-treated and admitted cases for 2010 to 2020 to update earlier information. And I also looked at recent literature and particularly at action since the 2018 Australian Senate inquiry. So in terms of deaths in Australia, we're aware of 151 deaths in all age groups for the 2000-2018 study period. And this included 3 pedestrians, and the remainder were users of motorised mobility scooters. The deaths averaged 7.9 per year. And of users, 148 users died, and more than 93% of these were aged equal to or greater than 60 years, and nearly 80% were male. Of hospital-treated user injuries, and Victoria has probably the best available state data. There's no real national data. So I'll be talking about Victorian data from 2010 to 2020, 11 years. And in that time, there were 1,310 ED presentations. A large proportion, 44%, were quite elderly, 80 years or more, and 59% were male, as compared to the 80% among deaths. Most were 60 years or more, and a very high proportion, 57%, of those who presented to emergency departments with injuries were admitted. So just to, we have problems with data, just as for the e-scooters. So we've tried to do some estimates. In Victoria, we know that falls make up 60% of the older motorised mobility scooter user admissions to hospitals. And we know from some Australian data from the AIHW that there's an estimated average 536 older, more than 60 years or more, users motorised mobility scooters who have fall injuries each year. So we extrapolated from the Victorian proportion of fall injuries to estimate that in total, there are approximately 900 hospital admissions of the older users each year in Australia. That is 450 admissions per 100,000 motorised mobility scooters. And that number of scooters is based on estimates for the Senate inquiry for all motorised mobility devices. It includes wheelchairs. It was estimated that there were more than 156,000. I've used a higher estimate just for motorised mobility scooters of 200,000. But that leads us to this hospital admission rate of 450 admissions per 100,000 motorised mobility scooters, which is quite high, and even that might be conservative. So just comparing deaths with hospital admitted and emergency department treated injuries by some of the risk factors. The mechanism of injury for deaths was 62% struck by motor vehicle, whereas this was much lower for admissions and presentations. Fall deaths were 22%, but this proportion was much higher for the admitted and emergency department cases. Roads and highways, footpaths were the predominant location for deaths, 84%, and this was closer, under 50% for the admissions, whereas the home became a more prominent location for admissions and presentations. Multiple injuries was the major cause of deaths, followed by head injuries. Head injury proportion was fairly consistent across deaths, admissions and presentations. And leg injuries became more prominent for the hospital treated cases. So the Senate inquiry recommendations from 2018 were supported in principle by the Australian government in 2019. And in summary, there were only two recommendations, which I've summarised into one statement, and that is that Austroads be funded to undertake research and consultation to inform the establishment of a nationally consistent regulatory framework for motorised mobility devices, including wheelchairs, including simple, low-cost licensing and registration and third-party insurance. So following this, Austroads published a discussion paper in 2019 that focused on adoption of the Standards Australia Technical Specifications for Motorised Mobility Devices, that was published in 2018, and consideration of licensing, registration and third-party insurance. And this project by Austroads was finalised in 2020, and its recommendations were that if the technical specification is adopted, industry-driven adoption should be considered. These labels in the photographs, the blue label is intended for motorised devices that meet public transport requirements, and the white label is for other public infrastructure such as paths. Second recommendation was that unladen motorised mobility scooters mass should increase to 170 kilograms in the Australian road rules. And importantly, that no further action should be taken on licensing or registration. And finally, that third-party insurance continues to be considered at the jurisdictional level. There have been some other developments since the Senate inquiry. There's an ongoing review by the Therapeutic Goods Administration to determine whether motorised mobility scooters are excluded products. That is, they should be regulated as consumer goods by the ACCC. Another development has been the impending modernisation of the disability standards for accessible public transport, due by late 2022. And the National Transport Commission proposed new Australian road rules into model legislation, which is currently with the ministers nationally. This is to classify these devices as pedestrians, that is, legalise use on public infrastructure, increase the weight limit, and permit speed up to 10 kilometres per hour. But a number of gaps remain in knowledge and in action. The number of motorised mobility scooters and motorised mobility scooter users in Australia remains very unclear. Queensland has registration, and my recommendation is that we need registration nationally so we can at least count motorised mobility scooters, and possibly licensing for users. Detailed national injury data is not really available. We need specific motorised mobility scooter codes beyond the false code that more or less covers this in the ICD system. We need a safety systems approach that considers machines, riders, and the environment. But most work to date has focused on the machine. And user assessments and training are patchy and the quality varies. There needs to be universally available and possibly regulated assessments and training. There's slow progress on design improvements. We should regulate the Australian Bureau of Statistics technical specifications, in my view. There's limited research on such as on further improvements to the design, the specific injury mechanisms which really need to be determined, as Kirsten explained, as for e-scooters. Given the proportion of head injuries, the research is needed to determine the possible need for helmets. And there needs to be evaluation of interventions as they occur. Research funds are required for this, and several attempts by researchers to get national research funding have failed dismally. And the Australian product safety law remains reactive, deals with problems after they happen. And we need to adopt best practice revisions to this law, including a general product safety provision. So in conclusion, after 15 years of serious deaths and injury data related to motorised mobility scooters in Australia, we still have an ageing population and increased uptake of motorised mobility scooters. There certainly appears to be a very high injury rate, and effective interventions are limited. Also, benefits from the National Senate inquiry are yet to materialise, and product safety law review is to potentially include a general safety provision is remarkably slow. This was first recommended in the Australian Consumer Law Review report in March 2017, and there's still no conclusion to this. And this, of course, has relevance way beyond motorised mobility scooters to all Australian products regulated by the ACCC. And finally, I'd just like to acknowledge the National Coronial Information System and the Victorian Injury Surveillance Unit for providing the data which I need to update the information for this presentation. Thank you.
Thank you, Joan. I'm just going to take the screen back. So we have had a couple of questions that have come through. I might start with the one that's for you, Joan. So you spoke about the evolving legislation and registration requirements regarding mobility scooters. What is the best way that our attendees for today's webinar can stay informed of these evolutions?
Well, in terms of registration and licensing, there's really been a decision not to take those forward nationally. I think because Queensland has this system for registration, which also permits third-party insurance developments, I think all the people in each state should encourage their own state to adopt the Queensland approach. That would be a starting point. It's hard to see that there'll be national action after a national inquiry has just determined that it shouldn't happen.
Yeah, that does kind of take us into the next question, actually. So this one's for you, Kirsten. So you said that conversations need to start early and highlighted the importance of interagency partnerships. Do you have any tips for those of us that want to start this in WA?
It's probably been quite a long process in Queensland that we've established those partnerships, but I think even reaching out to the different groups, like we try and make sure that we have short briefing type reports that we provide to our partners and try and think about what lens they would be looking at the data from so that we can present things in a way that addresses the kinds of questions they have, because I think we can fall into the habit of thinking from our own perspectives and thinking we just need to publish academic articles and and doing that kind of thing. I think, you know, really trying to think about what the priorities of those other agencies are, presenting brief snapshots for them and asking for those opportunities to have conversations with them. That's probably where we started from. A lot of them are existing relationships that we have now, but they've built up over time from, you know, those little steps at the start.
Yeah, thank you. I think there's a lot that we can learn from what you've done in your jurisdiction. We have had one more question come through for you, Joan, and that is, what training is recommended for new mobility scooter users?
Yes, the occupational therapists are the experts on training, and I think it's probably best to consult some of the websites of some of the occupational therapy groups to look at what they're doing. It really involves assessment as well as training, because given that we're often talking about very frail elderly users, they need to be competent to use the device, and then trained in accordance with best occupational therapy practices to use the device safely. And we see all sorts of mechanisms of injury. Driving into objects is a common mechanism, for example. So just learning to control these very heavy and cumbersome devices, which tip over easily.
Yeah, are there any websites that you can recommend for people?
I don't have any to hand, sorry.
Yeah, no, that's okay.
Find probably best at the state level.
Yeah, that's not a problem. Thank you. So we are going to wrap up for today. So in addition to all of the research and resources that have been discussed today, I just want to highlight that we do have a range of fact sheets through our No Injury program that can be found on our No Injury website. And given that we've got a few local governments that have tuned in today, I also do just want to highlight that WALGA have recently released a discussion paper about electronic scooter shared services. And this just provides a little bit of context around the policy implications in WA for local governments regarding e-scooter shared services in WA. We do also have a range of upcoming training and events, as you can see on the slide at the moment. And as I mentioned earlier, we do run a range of different trainings across a broad range of injury issues. So recommend everyone stays tuned by keeping an eye out on our No Injury e-news and on our website as well. If you are interested in keeping the conversation going, I encourage you to join up to our Connected program. So Connected is our online networking program. It provides you with the opportunity to build your professional network. You'll be randomly paired with another person in the program every 2 months. And then you'll be encouraged to reach out to them and have a 15-minute conversation with someone else that's just working in the injury prevention space as well. And I also just want to finally remind you that when the webinar ends, we will have an evaluation form that will pop up. We really value your feedback, and I do encourage you to just take a couple of moments to complete our evaluation form. It really helps us to ensure that we're providing professional development opportunities that are valuable to you. So I just want to say a huge thank you to Kirsten and Joan for presenting today, and for everyone for tuning in. We'll send you the recording of today's webinars along with some other resources following this. If you have any other questions, please feel free to reach out to us via the details that are on the screen now. So thanks everyone, and have a great day.
Thanks, Jay.